Perfect. Okay, so hello everyone, and welcome to the Venous and Lymphatic University. My name is Michael Sadek, a vascular surgeon from New York University Langone Health. And today we have with us Cassius Ochoa Chaar. And Dr. Chaar is Associate Professor of Surgery at the Yale School of Medicine. He is currently the program chair, which is a very big job, of the American Venous Forum, and he's right in the midst of it in planning. He has extensive experience with all vascular pathologies and in particular has an interest in venous disease. He's had a prolific research career so far as well. And for today's topic of conversation, he serves as the highest enrolling principal investigator for the VenoValve trial, a potential breakthrough treatment for the management of symptomatic deep vein reflux. So thank you so much, Cassius, for being here with us. And it's a pleasure to have you.
Thank you very much, Michael. It's a pleasure to be on this program, and I look forward to chatting about the SAAVE trial and the VenoValve.
Amazing. So I guess let's just start out with the basics. Tell us a little bit about deep venous reflux. It's one of these things that we know about, we talk about. There's not much that we really do for, but perhaps give us your perspective.
Yeah, so as you mentioned, deep venous reflux is common.
Yeah.
It's approximately, if you take all patients that we treat for superficial venous disease, up to 20%, if not more, can have deep venous reflux. And if you look at the cohort of patients who have ulcers and or history of ulcers, the C4 to 6 categories, which are the patients that struggle more with the disease, the percent of deep venous reflux becomes even higher. And it's probably one of the reasons of recurrent ulcers that's really untreated. At least in my practice, before having access to the VenoValve, I had numerous patients and several patients that would come to me year after year, sometimes with heaviness and pain, but sometimes with recurrent ulceration. And all that we did for them is give them stockings, give them unna boots, give them higher compression stocking, longer stockings. But really, we have not had a surgical treatment for that disease. Now, having said that, there are certain centers in the world, as you know, that do
Sure.
valvuloplasty or transposition of valves or transplantation of valves from one side to the other. The experience has not been very well reproduced. Um, I personally have not done a venoplasty or have not met anyone who has done it. And it's kind of hard to just decide, hey, I'm gonna start doing those, and especially that the percentage of patients that require that, they're a little bit higher risk. And if you don't have a clear vision that you can do something to help them, it's hard to embark on that. So the VenoValve brought a device that in a relatively straightforward, uniform procedure where we can implant a valve, prosthetic device, and that can serve as the function to decrease the reflux in the lower extremities. And the preliminary data from Colombia, as you know, was very reassuring and promising.
Colombia, the country.
Colombia, the country, not
Yes.
not your neighbor in New York.
Yeah. No, I mean, it's true. I think I have to echo a lot of the statements. Even in my practice, I've always been amazed by the many videos of the surgical procedures for treating deep venous reflux. But it is a steep learning curve, and really it's few of us that have mastered those techniques and skill. Maybe there's something to be said about that, but certainly there's a need to advance this field in one way, shape, or form or another. And implants have been tried in the past. The preliminary data are interesting. Do you think there's something about this that makes it a little bit more unique compared to previous prosthetic valves, or?
Yeah, I think it's a bioprosthetic. It's decellularized. We've used some in maybe not in functional valves, but But similar, valves have been used, bovine valves have been used for the heart. And, like, the evolution of bioprosthetic and then prosthetic hearts in the valve, I foresee that a similar evolution will probably happen in the lower extremity valves. And, the preliminary results are good. And I'm sure that, this is kind of first step into going into that field and hopefully advancing it.
Hmm. And just you've done more surgeries than anyone, because you are pretty much the highest enroller. How is the surgery itself?
It's actually
Yeah.
a relatively straightforward surgery. It is challenging. There's a lot of collaterals when you dissect those veins, especially when you're treating post-thrombotic patients.
Right.
And uh, and sometimes you have to make a judgment in the operating room whether you have to patch the vein or whether the vein is big enough. Uh,
Hmm.
and that was probably the challenge, especially in the first 2 to 3 that I've done a total of 7. And I
Hmm.
think the first 3 we had to use a patch
Mm.
to fit the prosthesis, and it was a little tricky. Um, but we're able to do it, and
Yeah.
they've all done
Yeah.
fine.
But overall, the open femoral vein exposure, putting in the valve, closing it up it's a surgery, but it was
Correct.
straightforward. Yeah.
Pretty much within the skills of I would say every vascular surgeon.
Hmm.
It's not much different than dissecting an SFA or common femoral.
Right.
It does have a little just paying extra attention to the amount of tributaries, and also sometimes making decision if there's a big collateral or in the area that maybe potentially could drive reflux around the valve. You want to try to ligate those, and this is where that skill and that experience and that surgery for deep venous reflux will probably evolve as more people do it. And hopefully if the device gets commercialized and we can use it on our patients, then we can build that experience and that knowledge.
Sure. Absolutely. Well, thank you for all of that, just general insight into the procedure, et cetera. You mentioned some data that seemed pretty promising. I know that you've presented on the data, and you potentially have some of that information. I know that I was very interested, and others have been rather, they found the data pretty remarkable considering how many prior devices, et cetera, have not shown promise, and this is kind of starting to show something interesting. So if you have any of those data to share with us, I think we'd be greatly appreciative.
Sure. So we presented initially, and I can share some slides if you'd like. If you let me sharing, if you allow me to share, then I can share. I'm not
Sure.
allowed to share.
Absolutely. Absolutely.
So we presented 2 sets of data, or at least I presented 2 sets of data. The first set was during the Venous 2024 last year at the American Venous Forum meeting. And basically we showed 6 months data on all patients, and in the trial 75 patients were totally enrolled. And I'm going to share here the slide. Can you see my slide?
Yep. Absolutely.
Yeah, so if you look at all patients who enrolled in the SAAVE trial, you can see that the VCSS score decrease, which was from 16.37 to 10.25 in the total cohort. And that's a pretty significant drop. It's a good, I would say more than 40% drop in the mean VCSS score. But then if you look at the patients and the percentage of patients that had improvement, you can see that almost 90%, so most patients had some decrease in VCSS score. And if you look specifically at a meaningful, significant decrease in VCSS score, so a drop of 3 points or more, you can see that almost 3/4 of the patients had some significant or clinically meaningful improvement, which is pretty good for a patient population that we really did not have anything to offer except, compression therapy and local wound care. So these were the main take points from the first
Right.
presentation of all patients.
And these
Now,
patients all presented with severe disease. These are all C4,
correct,
5,
correct,
C6. Yeah.
correct. So these are patients that are C4B to C6. So all
Yeah.
of them either very advanced disease or ulceration or history of ulceration. And all those patients do not have superficial venous reflux. So if they have saphenous vein that was refluxing, that was treated before enrolling the trial. If they have deep venous disease or iliac vein outflow obstruction, that was treated before enrolling the trial. So really, these are the patients that we see that we have no more options. These are the no option venous disease
Yep.
treatment. And a good portion of those, approximately, the majority presented with ulceration.
Sure.
And we did present the data on ulceration during VAM, and I will show you what the results on the patients with ulcers. So just so that you get a flavor of those patients. So 41 out of the 75 patients had ulceration, and 31 out of the 41, so 75.6%, the majority of patients had an ulcer for more than 1 year.
Right.
These are patients who are basically living in an agony and local wound care,
Hmm.
constantly for their
Yeah.
lives.
Local wound care, which is, it's clearly less than effective.
Correct.
Yeah.
Um, so so when we looked at those patients, you can see that the total surface area of the ulcers, which was 17.4 centimeters square at baseline, went
Hmm.
down at 1 year to 0.1 centimeters square. So a remarkable drop in the total surface area of ulceration.
Yep.
And some patients had one ulcer, some patients had more than one ulcer, but we're looking at the total area of ulceration in all the legs. And if you look at the reduction in surface area, you can see that in the beginning, in the first month approximately, there was a big drop in the reduction of the surface area, and that continued up to a year,
Hmm.
slowly decreasing. Um, and if you look at the patients, the percent improvement or healing of the ulcers, you can see that the percentage reduction in ulceration was close to 50% in the surface area healing and 80% improvement. And looking at the patients, so 50% of the patients healed their ulcer at 1 year and 90% had some improvement. So the majority of patients that got the VenoValve improved and seemed to continue improvement up to 1 year. Now, that was presented in June, and based on the data that was available in June,
Hmm.
uh, we're working currently on gathering all the data. We actually enrolled the last patient in the trial, and we recently, got the 1 year follow-up, and the patient got significant improvement. And I think the company is and the trial is trying to gather the data to finalize it, and hopefully we'll have we're thinking about the AVF Venous 2025 to present the data on the 1 year trial as a late breaking.
Hmm.
And so for everybody who's listening, you should definitely attend Venous 2025, not only for this trial and deep venous ulceration, but for all kinds of venous therapies. There's always great science, great data, and great camaraderie.
Great. Well, thank you so much for all of those insights and for resharing some of these data from the
My
AVF
pleasure.
and from VAM. It's really really eye opening and really remarkable what this technology and a lot of what I gather is that we don't even quite know how it works. It's tough to really see improvements in the metrics with the venous duplex ultrasound. What are your thoughts about that? I know you kind of alluded to the end result, which is what we're looking for.
Correct.
Yeah,
So
yeah,
I'm to be honest, I'm not privy to that data,
yeah, yeah,
and but I
yeah.
know that the it's beyond just reflux. beyond the measure of reflux, and there has been some challenge in measuring the reflux. And as
Sure.
there later in the trial, there was basically there are texts that come to every ultrasound to make sure
Yep.
that the technique of measuring the reflux is accurate.
Absolutely.
And part of involving companies and being able to have a device and to help the patients is also the opportunity to study this in a better way.
Mhm.
And hopefully, that will be something that we'll be able to do, you and I and
Yeah.
every person who's interested in venous care and taking care of patients with the venous reflux.
Totally. So you don't have a crystal ball. You may or may not be privy to certain information, but when are we going to get this? If you had to guess,
When are we going to get what
when are we going to have access to the VenoValve? When's it going to get?
the
When do you think?
VenoValve?
When, if you had to guess?
So my understanding is after the 1 year data is all completed, I think there probably be an attempt to try to get approval,
Get
but
approval, and then
I'm not sure of the timeline.
yeah, and then it's 6 months, 1 year, who knows? And then it goes back and forth with the FDA, as the
Exactly.
usual story goes. And what do you see in the future? What do you think is you kind of alluded to this a bunch already, that this might be the first iteration of what's happening. Well, what do you
Yeah.
see going forwards? What would
So
you like to see
what
even?
I hope to see
Yeah.
exactly is a a controlled and monitored deployment of the technology,
Mm,
similar to what happened with TAVR,
mm,
where centers that want to use this technology be held to high standards. Same for surgeons who wants to use this technology,
mhm.
and to be able to standardize the reporting outcomes and this patient selection, because I think like a lot of things in vascular disease, you really have to pick your patients right, and that's the key. And I think if we do that, I think we'll have a lot of that field will really expand, and we'll be able to help a lot of patients. And we're starting with open valves. I'm sure there'll be room for open valves, but we're vascular surgeon. We do open, we do endo, we do hybrid, and I think endovascular therapy has been already launched also by other companies. I think in Colombia for a
Mhm.
percutaneous stent valve. Um, other attempt at you know creating limited dissections as valves has been tried. It hasn't worked, but I'm sure there's iterations and lessons learned from those trials where the technology can reshape and potentially improve.
Sure, absolutely. Well, on that note, thank you so much for all of your insights and for taking the time to explain this really complex but unbelievably interesting and sort of almost avant-garde topic. Thank you again.
Perfect. Thank you very much, Michael. It's been a
Yeah,
pleasure
thank
chatting
you,
with you.
Cassius.
Thank you
Pleasure.
for inviting me.